Welcome back to Ronnie, I'm Joe B. Today we'll go over a manual therapy technique and exercises that has worked for my patients in reducing their round back posture. Let's dive in. A bilateral thoracic flexion dysfunction is when the superior and inferior facets are stuck upward and forward. This results to an increase in thoracic kyphosis. The cause of this can be due to pectoralis muscle tightness, faulty rounded shoulder posture in sitting, and mid-back or scapular weakness. This can bring about a chronic, localized dull aching pain on the mid-back. There will also be a presence of rounded shoulders during postural assessment, with limitation of motion seen towards shoulder flexion and thoracic extension. The assessment for a flexed thoracic vertebrae. In this animation, we will assume that it is the T12 that is stuck in flexion. There are two types of tests that determine thoracic asymmetry: the seated thoracic flexion test and the seated thoracic extension test. To make that vertebrae stick out, you need to select the seated thoracic extension test. Patient is in a short sitting position, feet flat on the floor and arms across the shoulders. The therapist will be behind the patient. The lowermost lateral rib number 10 is palpated first by the web space of the therapist's hands. Then the dominant hand thumb will reach across to arrive at the T12 spinous process. From there, the thumbs move one finger breadth laterally to arrive at the transverse processes of T12, which will be the major landmark to palpate to determine the presence of a flexed vertebrae. The patient is then asked to arch or lift the chest up for thoracic extension. When doing this assessment, always start by palpating the T12, then go superiorly until you arrive at the T1 to finish all the thoracic vertebrae, as needed. Normal findings are that all the lumbar vertebrae transverse process should move forwards or become less palpable, with the ribs tilting backward. Abnormal findings to confirm the presence of T12 bilateral thoracic flexion is that both transverse processes will become more prominent as compared to the above and below vertebrae during seated thoracic extension, since the T12 facets are stuck upward and forward. For the treatment, for instance, your T12 has the bilateral thoracic flexion dysfunction. The objective is for the T12 to improve its individual extension motion, and this can be attained through a thrust manipulation. Patient is in supine with hands across the shoulders and closer to one edge of the table. The therapist will be on the side where the body is close to the edge of the table. The right hand rotates the torso to the left to position the left hand on the target vertebrae that requires extension mobilization. The left hand pistol formation is placed behind the vertebrae to be manipulated such that the spinous process sits on the first dorsal web space, while the transverse processes of the vertebrae sits on the index finger and the thumb. The patient is then moved back to supine with the right hand supporting the patient's head. A high velocity, low amplitude thrust is delivered through the therapist's lean on the patient's chest, and this is done for 1 to 2 reps. A cavitation can be felt in the spine. For the exercise, a seated thoracic extension active range of motion exercise can be done for 1 to 10 reps, progressing to 30-second hold times for 3 reps. Same with half kneeling wall slides, since the shoulder overhead motion can also increase thoracic extension. So do you want to learn how to elongate the thoracic spine for decompression? If so, then watch this next video. Thank you so much.